Today's topic is on hyperthyroidism. Good morning, I'm Dr. Sneha, uh, working as assistant professor in D.Y. Patil Medical College, Kolhapur. First, we need to understand the difference between thyrotoxicosis and hyperthyroidism. Thyrotoxicosis is a clinical state in which there is high production of thyroid hormones, irrespective of source of thyroid hormones, and hyperthyroidism is a form of dysfunctional thyroid gland itself. So it's a form of thyrotoxicosis due to inappropriately high synthesis and secretion of thyroid hormone by thyroid gland itself. So to make things easier, today we are going to discuss first introduction, definition and etiology, clinical features, management of thyrotoxicosis, and to highlight on subclinical hyperthyroidism and thyrotoxicosis in pregnancy. So to start with, we have etiology of thyrotoxicosis, where thyrotoxicosis caused by hyperthyroidism and thyrotoxicosis without hyperthyroidism. So first we are going to see the common causes of thyrotoxicosis associated with hyperthyroidism. Mainly, most predominantly, the Graves' disease is the most common cause, where there is production of abnormal thyroid stimulator, and sometimes there is nodular goiter, uh, most commonly toxic nodular goiter or multinodular goiter, or the second one, that is solitary toxic adenoma, where there is thyroidal autonomy. And thyrotoxicosis not associated with hyperthyroidism. It is inflammatory disease or thyroiditis, silent painless thyroiditis including postpartum, painful subacute thyroiditis, probably viral etiology, and extrathyroidal source of hormone, excess intake of thyroid hormone, iatrogenous or factitious. Then there are some uncommon causes, that is production of thyroid stimulating hormone or thyroidal autonomy, drug induced hyperthyroidism, in that there will be TSH secreting pituitary adenoma or pituitary resistance to the thyroid hormone, the neonatal Graves' disease, human chorionic gonadotropic secretion, hyperemesis gravidarum, or there can be activating mutations in TSH receptor, stroma ovary, and drug-induced hyperthyroidism, most commonly those which are containing iodine or iodine-containing drugs, that is amiodarone, and radiographic contrast agent. Then inflammatory diseases, like it could be due to drug-induced thyroiditis or acute infectious thyroiditis. Radiation thyroiditis could be also there. As we have seen that most common cause of thyrotoxicosis is Graves' disease, so it contributes about 60 to 80% of cause of thyrotoxicosis. It's most commonly found between 20 to 50 years of age. It can also occur in elderly, but before adolescence, it is very rare. What causes this thyrotoxicosis? It could be due to a combination of environmental, genetic factors, including polymorphism in HLA-DR, CTLA4, CD25, PTPN22. These are the genes, a T cell regulatory gene and TSH receptor, which contribute to Graves' disease susceptibility. These also, where there is thyroid associated ophthalmopathy, the cytokines play a major role to cause this thyroid associated ophthalmopathy. Coming to the clinical features, excess thyroid hormone affects every organ of the system, predominantly on cardiovascular system, eyes and skin. Then there are other system involvement like neuropsychiatric system, GI system, musculoskeletal system, reproductive system, and there could be a neck swelling. So patient can present with palpitation, shortness of breath, tachycardia, systolic hypertension, high output failure. In eyes, he may experience soreness, grittiness, tear, eyelid retraction, periorbital edema, exophthalmos, ophthalmoplegia, and neuropsychiatric symptoms. He may experience fatigue, nervousness, anxiety, hyperactivity, poor concentration, and in gastrointestinal system examination, he may have increased appetite, but at the cost of weight loss. Even uh, diarrhea would be a common symptom for gastrointestinal involvement. Musculoskeletal system, weakness, fine tremor, muscle wasting, hyperreflexia, periodic paralysis, and reproductive system. Patient can have amenorrhea or oligomenorrhea, infertility, neck swelling, goiter, obstruction of surrounding organs, skin, heat intolerance, warm, moist skin, increased perspiration, hair thinning, hair loss. Cardiovascular symptoms. Cardiovascular symptoms often predominant in patients with thyrotoxicosis. Cardiovascular manifestation are prominent, especially in elderly. So atrial fibrillation is very much common as a cardiovascular symptoms, and which may lead to embolic events. So all these uh, in the diagram, it's showing that reduced systemic vascular resistance, increased venous rhythm, increased blood volume, increased myocardial contractility, increased oxygen consumption, decreased exercise capacity. All these will lead to inadequate increase in cardiac output. Then coming to the eye features or ophthalmic features, it's an autoimmune phenomenon. It can be present before, with, or after thyrotoxicosis. 25 to 50% of Graves' disease develop clinically evident orbitopathy, and 3 to 5% may suffer from severe disease. It could be thyrotoxic or infiltrative, and the most common risk factor for ophthalmic features are those patients who are smoking. Symptoms: patient may experience with blurred vision, easy tiring of eyes, photophobia, double vision or diplopia, irritation in eyes, excessive tearing, and in severe cases, patient may also have decreased vision. Sympathetic overactivity causes lid retraction, lid lag, jerky lid movements, lid tremors, and these may be present in all forms of thyrotoxicosis. Infiltrative, suggestive of Graves' disease. It consists of exophthalmos, lagophthalmos, periorbital edema, corneal ulceration or infection, subluxation of the globe, injected conjunctiva, and score this, there is clinical activity score as no specs. Um, As the disease progresses, acute inflammation resides, but the signs and symptoms improve only partially because of residual fibrosis and scarring of the orbital contents. As we go for the clinical activity score, 1.4 each for presence of spontaneous retrobulbar pain, pain on the eye movements, eyelid erythema, eyelid edema or fullness, conjunctival injection and conjunctival chemosis, swelling of caruncle. Score of more than 4 signifies active disease. We have this diagrammatic photographs for eyelid erythema, conjunctival injection, eyelid edema or fullness, chemosis, and swelling of the caruncle. So, no specs classification of thyroid eye disease. This is the American Thyroid Association classification of severity. 0 means no signs or symptoms. 1 is only signs, where limited to upper lid retraction and stare, with or without lid lag. Class 2 is soft tissue involvement, edema of conjunctiva and lids, conjunctival injection, etc. 3 is proptosis. Class 4 is extraocular muscle involvement. Usually patient may have diplopia. Class 5 have corneal involvement, primarily due to lag of ophthalmos, and 6 is sight loss due to optic nerve involvement. Dermatological features: skin may be warm, diaphoretic skin, and usually heat intolerant, especially on hand, and there will be rapid hair shedding, vitiligo, and there is classical pretibial myxedema found in small subset of Graves' disease, tends to occur in older patients. It's usually on the anterolateral aspect of the shin, but can also be other sides after mild trauma. It's non-pitting, thickened, indurated skin, usually asymptomatic but may be pruritic or painful. Lymphocytic infiltration of the dermis layer of the skin, accumulation of glycosaminoglycans, localized myxedema. Neuromuscular features, restless during history and physical examination, tremors elicited by asking the patient to hold a piece of paper over outstretched hand, simultaneously closing the eyes may enhance the tremor, to stick out the tongue. Proximal muscle weakness, patient finds to have difficulty in climbing the flight of stairs, reaching the arms over the head, standing from sitting position. This is one of the presenting, but it's very rare, most commonly in Asian males who have high carb meal and then steroid intake and insulin. There is muscle paralysis and hypokalemia, massive intracellular potassium deficiency. It's not because of actual potassium deficiency, but a shift. There is increased sodium potassium ATPase pump activity and enhanced insulin response postulated to contribute to hypokalemia. Treatment should be given as potassium chloride supplementation and non-selective beta blockers. Then gastrointestinal features, the gut motility is increased caused by hyperdefecation, necessarily but not necessarily diarrhea, leading to malabsorption of the nutrients. Symptoms of obstructive dysphagia due to large goiter and other autoimmune disease like atopic gastritis, celiac disease may be associated with Graves' disease. In reproductive system, men may have gynecomastia, women may have oligomelia, infertility. In bone health is also related to the high level of thyroid hormone stimulates bone resorption, thereby causing loss of both cortical as well as trabecular bone. Cortical bone more than trabecular. Greater risk of osteoporosis and thyrotoxicosis is there. High rate of bone resorption may lead to hypercalcemia. Clinical evaluation, the diagnosis of thyrotoxicosis is mainly based on clinical evaluation, biochemical evaluation to determine the etiology, and evaluation of organ system involvement. Then biochemical evaluation, the T4 total or free TSH required if clinical suspicion of thyrotoxicosis is present. In overt thyrotoxicosis, usually both free T4 and T3 are elevated and serum TSH is undetectable. Isolated T4 toxicity is common in elderly. T3 toxicosis referred to condition with normal T4, elevated T3 and suppressed TSH. It may represent earlier stages of disease or caused by an autonomously functioning thyroid nodule. Also seen in iodine deficient areas and in recurrent thyrotoxicosis. Evaluation to determine the etiology of thyrotoxicosis, we may need the radioactive iodine thyroid uptake technician scan and measurement of antibodies against the TSH receptor or TRAB antibodies. So to have this radioactive iodine uptake distinguishes high uptake hyperthyroidism from low uptake thyrotoxicosis performed with iodine 131 in India, and the patient swallows the radioactive iodine in the form of capsular fluid, and the absorption by the thyroid is studies to and after 24 hours. The dose is typically 5 to 10 microcurie sodium iodide. Normal 24-hour uptake is between 15 to 25%. Simultaneous use of iodine, that is amiodarone, thyroid or antithyroid drugs, impedes the uptake of radioiodide. The test is contraindicated in pregnant and breastfeeding. If it's high, it's due to Graves' disease. High or normal radioactive iodine uptake indicates no synthesis of thyroid hormone. and low, it could be due to thyroiditis or drug-induced thyroid disease or metastatic thyroid cancer or factitious thyrotoxicosis. So low radioactive iodine uptake indicates either inflammatory destruction of the thyroid gland resulting in transient release of performed thyroid hormone or use of excess exogenous thyroid hormone medication. Then there is technetium scan performed with per technique 99. It is done with IV injection 15 to 20. It's more rapidly, readily available and more rapid examination is convenient. Disadvantages are isotope is captured or trapped by the thyroid but does not enter the synthesis pathway. Activity in esophagus or vascular structures can be misleading. So this is the technetium scan where you can see that there is normal uptake and there is high uptake where we call it as Graves' disease, and if it's low uptake it is thyroiditis. Measurement of antibodies. Clinical utility is limited. Antibodies against TSH receptor and pathognomic of Graves' disease. They are detectable in serum. 98% of untreated patients with Graves' disease. The detection of TRAB antibodies rules out other causes of thyrotoxicosis. So, to have a look at the algorithm for diagnosis of thyrotoxicosis, if TSH is less than 0.4 microunits per ml, it is thyrotoxicosis. Then we have to check for free levels of T4 and T3. If free T4 is normal, free T3 is also normal, we suspect it as a subclinical hyperthyroidism and repeat TSH and all the free hormone levels in next 2 months. If the free T4 is normal and FT3 is elevated, it is because of hyperthyroidism. And even if the FT4 is elevated, it is also due to hyperthyroidism. Then we can go for the technetium scan or radioactive iodine uptake. If it is low and it is painful, it is due to subacute thyroiditis. If it is not painful, it is due to postpartum thyroiditis or silent thyroiditis. If it is normal or high, it is due to diffuse goiter, that is Graves' disease, and nodular goiter. If it is there, then it is due to toxic solitary nodule or multinodular goiter. And if the TSH is low and FT4 and FT3 is also low or normal, then we can suspect it as central hyperthyroidism. Coming to the management, as we can see that Graves' disease is a classical triad of diffuse goiter, orbitopathy, dermatopathy, and fulfills the criteria through may not always present. So medical therapy would be thionamides, carbimazole, methimazole, propylthiouracil. Other treatment options are surgery and radioactive iodine therapy. Thionamides inhibit the thyroid hormone synthesis, that is thyroglobulin. It doesn't allow to have iodinization because of this thionamides. It blocks this pathway, and usual dose of carbimazole is 20 mg, where we can also have other options like methimazole, that is 15 mg. And if we are using propylthiouracil, we have to use around 100 mg of the dose. Carbimazole is a prodrug for methimazole. The starting dose of carbimazole is about 30 to 40 mg per day. All patients should have hemogram and liver function test before starting thionamides. Carbimazole start with 30 to 40 mg per day. Clinical improvement takes with 4 to 6 weeks. Monitor FT4 after 6 to 8 weeks. If free T4 normalizes by 6 to 12 weeks, TSH may take longer to normalize. Taper dose by 10 mg and maintain euthyroidism for 1 to 1.5 years. Maintenance dose, we can keep it to 5 to 10 mg. Propylthiouracil is related to acute liver failure. It has led to, so it is limited to use till first trimester of pregnancy. short half-life. Then side effects are agranulocytosis, rash, joint pain, autoimmunity, hepatitis, vasculitis. Adjunctive therapy would be beta blocker, non-selective, propranolol 40 to 120 mg per day, metoprolol, atenolol, symptom. We have to control the tachycardia of the patient. So in summary, the Graves' disease, antithyroid drugs, TSH, FT4 and every 4 to 6 weeks, titrate the dose. Once controlled, monitor 3 monthly and treat for 1.5 years. If remission, then retest yearly. We can also use glucocorticoid therapy, pulse therapy. We can use IV glucocorticoids like methylprednisolone, which may take, or you can use methylprednisolone in a tapering doses. Prednisone 40 mg per day in a tapering doses over a 4 weeks of duration. Coming to thyroid storm, it's known as thyrotoxicosis crisis, represents severe and end of spectrum of thyrotox characterized by compromised organ function. It is an endocrine emergency, non-compliance to antithyroid drugs, risk factors, infection, trauma, thyroidectomy without proper preparation, and thyroid manipulation. It can cause hyperthermia, tachycardia, sweating, anxiety, vascular collapse, diarrhea, vomiting, respiratory paralysis, coma. Treatment is preferably done in ICU care setup, supportive therapy, admission in ICU unit. We have to treat the fever with paracetamol, external cooling, replace the fluid losses, antibiotics. It's not such of use. And then reduce the thyrotoxicosis, preferably the propyl thiouracils and Lugol's iodine or saturated solution of potassium iodide. Other treatments are beta blockers, rate control, blockage of peripheral conversion, and thyroid hormone in a minor propranolol. Subclinical hyperthyroidism. It's a normal serum free T4 and normal T3 or free T3 and subnormal TSH concentration. The symptoms are usually two non-specific: exogenous causes and endogenous causes. Overzealous thyroid hormone replacement, and endogenous would be overt thyrotoxicosis in a milder form. Toxic multinodular goiter is probably the commonest subclinical thyrotoxicosis. Clinical signal may be prone to atrial fibrillation or higher cardiovascular mortality. We can treat this patient treatment similar to overt thyrotoxicosis. Radioiodine can be helpful. Beta blockers and a long-term anti-thyroid drug therapy treatment of choice. Thyrotoxicosis in pregnancy, it could be because of Graves' disease or HCG-mediated hyperthyroidism, may be present prior to pregnancy. Presence of goiter or orbitopathy may be very severe. Positive TSH receptor antibodies, and first trimester we have to treat with propyl thiouracil followed by carbimazole, and surgery for uncontrolled cases. HCG-mediated hyper alpha unit, a subunit of HCG, simulate the TSH and may present with transient thyrotoxicosis, hyperemesis or trophoblastic hyperthyroidism. Usually less severe, occur transiently in first half of gestation. The treatment is symptomatic and supportive. Thank you.